Thank you so much, Dr. Fatma, Dr. Reem. Thank you all for attending. I would like to start by thanking the organizing committee and Dr. Saeed Al-Shayban for this invitation. Today, I will try to talk about the molecular diagnostic in lymphoma. So you are familiar with molecular and myeloid neoplasm. It has been very advanced to the degree that it's become part of the diagnosis and also part of the workup for every case, let's say, of leukemia or MDS. Now, there is advances in solid tumor, and lymphoma is also taking a large chance of new mutations, new genomic data that change the perspective of lymphoma. But again, all of these advances in molecular, it's only an ancillary. Still, we need the morphology. Still, we need a more comprehensive approach. So we need the clinical, we need the morphology, we need the IHC, we need the karyotype, cytogenetics. Everything is needed for the having more comprehensive information and to understand the biology of these tumors. Once we understand it, this can guide the therapy. You can get a better in terms of prognostic and also detecting the relapse. Now, when we do molecular testing, there are many targets for us. So when we say molecular, we mean DNA or RNA. DNA or RNA, this is what we are looking for. But sometimes we look at rearrangement, like physiologic rearrangement, similar to somatic hypermutation, for example, or when we do IGHV hypermutation. We see this as physiologic changes to increase the diversity of lymphocytes and can be pathogenic, like with MYC rearrangements and others. The same thing with mutation. It could be small deletion or insertion. It could be single nucleotide variants. It could be small deletion or silencing. It could be duplication, amplification. So all of these changes as a copy number, as a mutation, as insertion or deletion, all of that can be detected using different methods. Why we do molecular tests? We do molecular testing either for diagnosis, so it can help in lymphoma to differentiate reactive from neoplastic process. We do it for classification. There are some diseases that you need this mutation to document the diagnosis. Many mutations has prognostic significance. It can be used for MRD and monitoring. So with time, even after therapy, we can detect these mutations before the patient develops relapse. Targeted therapy, which is also a new thing. So there are many medications now that target specific mutations within the lymphoma world. And it can be helpful to detect cryptic abnormalities that can be missed with normal karyotype. Now, I decided to make this talk more to pathology rather than technical. So I will not go deep into the technology, how we do the FISH or karyotype or chromosomal microarray, but these are the list of the molecular techniques that's available in my lab. So we can do all of these testing. We can do IGHG rearrangement. We can do IGHV mutational analysis. We can do minimum residual disease testing, next generation sequencing with different targeted. We can do gene expression profiling. We can do epigenetics testing or cell-free tumor DNA. All of these are methods used in the lab to answer questions related to DNA or RNA abnormalities within the world of lymphoma. So from now then, the important thing here that every test answers different question. So we need all of these tests. No one can replace the other. And each test has its own limitations. So some abnormalities can be detected by NGS and missed by FISH. The reverse is true. You can detect clonality by NGS, and that's missed by fragment analysis. So the BCR is different than NGS, different than Sanger. It's different technologies, but they work on the same target. Trust me, you will not get any technical beyond this. Now, we'll move to disease-based update in terms of genetics for this lymphoma. We'll start with the CLL, SLL. This is one of the commonest lymphoma. It can be tissue or can be liquid. And there are multiple cytogenetics abnormalities that have been described. So some of them has favorable and very common, like 13q deletion, trisomy 12, intermediate, associated with bright CD20, 11q, 17b deletion with TB53, that's very significant. MYC mutation is very rare in CLL. And there are other cytogenetics abnormalities that's not that common. Also, complex karyotype can be seen. The most important thing for us is to do IGHV mutation and status. It's now part of management for every patient with CLL, SLL. It's recommended. And the mutated CLL associated with indolent behavior. With mutated, we mean that the score is 97 and below. So if the score is 98 and above, this is unmutated CLL and likely associated with bad prognosis, and it will change the therapy. So the management for unmutated CLL is different than mutated CLL. Cases with borderline, anything between 98 to 97 is considered as unmutated, so similar to bad prognosis. Now, in terms of therapy, TB53 is very critical and CLL, and as you can see, there are 3 FDA-approved medication. Sorry. There are 3 FDA-approved medication to use in patients with TB53 mutation or deletion in TB53. Also, if you have loss of heterozygosity, so sometimes the FISH is negative, so there is no deletion in TB53, there is no mutation in TB53. If there is loss of heterozygosity, still it will be considered similar to TB53 mutation or deletion. Again, you know, TB53 is important in most lymphoma. It's always associated with wars, so we see it even in solid tumors. It's part of the cell cycle. The critical here is there are many other mutations described in CLL. So you have Notch1, SF3B1, ATM, and others. There is BTK, so BTK and BLCG2 and CARD11, all of this predict resistance to BTK inhibitor. So if you have a patient with TB53 mutation, you offer them BTK inhibitor. If they have another mutation in BTK, then they will not respond to BTK inhibitor. And this is why we don't offer only one test. You should not do only TB53. You should do a comprehensive panel, all genes together, because some other gene may indicate resistance. The same thing if you have BCL2 mutation, then this patient will resist the BCL2 inhibitors. There are some genes associated with rectal transformation, like unmutated CLL, Notch1, TB53 mutation, or deletion, and deletion 11q. The next is LBL, Waldenström macroglobulinemia, and this is one of the diseases that also gets a little bit changes with WHO5. We know about MYD88. So MYD88 is common, seen in many cases of LBL, but it's not specific. So you can see it in other type of lymphoma. It's totally not specific. The importance of MYD88, it can work through BTK. So BTK inhibitor may work if the patient has this mutation. CXCR4 mutation present in some of these patients, but if there is CXCR mutation, then the patient will resist BTK inhibitor. So this is why it's important to do both mutation. If you do only one, you say MYD88, okay, I will give the patient BTK inhibitor. Maybe the patient has co-occurrence of CXCR4, and most patient has both mutation. So most patient has MYD88 and CXCR mutation together. If you have both, then this is very specific for LBL. If you have both, it's very specific. If you have only one of them, then you need strong morphologic evidence to support the diagnosis of LBL, because MYD88 alone is not specific. There are other mutations described in LBL, like mutation in BTJ1 and BRDM2, present in many cases. 6q deletion is present, and also other mutation described in LBL disease. Now, marginal zone lymphoma is one of the diseases that has 3 types. It's a more indolent type, so we know the splenic marginal zone, the nodal marginal zone, and the extra and the mucosa associated. So even though the nodal and splenic marginal zone, they are in different location, but you can see they share a lot of mutational profiles in terms of genomics. So they are KLF2 and Notch2 present in both. Trisomy 3 and 18 is common in both. And there are some other mutations. Neither of these are specific nor sensitive. But you can see if you have NGS panel and you find this mutation, it can support the diagnosis and if the morphology is not strong. In terms of extranodal or mucosa-associated marginal zone lymphoma, again, we know about all of these translocation, 1118, 1418, different location for all of these, and BCL10 and FOXB1 rearrangement in few cases. Again, the changes here is very specific for stomach, parotid, and thyroid, and areas where you see the mucosa-associated lymphoid disease. Next is follicular lymphoma. So now we are talking about classic follicular lymphoma. We move away from the gradings to classic follicular lymphoma and diffuse follicular lymphoma, pediatric follicular lymphoma, and GI follicular lymphoma. So with classic type, you see 1418 in most of the cases, but not all cases. So not all cases will have this translocation. Sometimes there is translocation, but the IHC is negative, and this is well known because of point mutation that change the epitope, so your antibodies will not work in these cases. Follicular lymphoma is very unique in terms, it has high rate of mutation in the chromatin modifying genes. So many genes is mutated. All of these genes fall into the histone and chromatin modification agent, either histone methyltransferase or histone acetylase, very common, especially EZH2 and KMT2D. And there are other cytogenetics abnormalities, 6q and 17b, like TB53 is associated with worse prognosis. The other type of follicular lymphoma, diffuse follicular lymphoma, where you have diffuse growth of follicular lymphoma, usually lack 1418, and there is mutation common, especially the STAT6. It can have also EZH2, it can be targeted, so we have a therapy for EZH2 now. Pediatric follicular lymphoma has also 80% of this follicular lymphoma has mutation in one of these genes. Duodenal lymphoma also have mutation in EZH2, CREPPP, and TNF-RS14. And you can see it shares between these. So TNF-RS14, you can see it's common in all of these. And for classic follicular lymphoma, if you find any of these genes, then it's associated with high rate of transformation to DLBCL, especially if there is MEK, BCL6 rearrangement, CDKN2A, B, TB53, and others. All of these associated with worse prognosis. So again, if you do more comprehensive genomic profiling and you find these, then you can have a better idea, because follicular lymphoma usually, again, indolent disease in some way, but if you find some mutation that associated with the progression to DLBCL, this may help the patient. Mantle cell lymphoma is well known for translocation 1114 with cyclin D1, but 10% will be cyclin D1 negative. This associated with cyclin D2 or D3 rearrangement. So if you do molecular testing, you can detect these. There are many cytogenetics abnormalities, blastoid variant and pleomorphic variant associated with TB53 and 9q deletion. If you find TB53 deletion or mutation, notch 1 or 2, ATM or KMT2D is associated with poor prognosis, short time to progression, especially with NSD2. NSD2 is recently described as one of the, it's not specific for mantle, but in mantle cell lymphoma, it's associated with progression and ibrutinib resistance. So this is a summary of what I described. And this is the maturation of B cells through the germinal center. So the unmutated CLL, it's like the most naive to all mature LBL, like memory cells. You can see many mutations happened in each disease. So with CLL, we have a list of mutation. With mantle cell, we have cyclin D1 and TP53. Burkitt lymphoma, I did not describe Burkitt lymphoma because Dr. Nasser already described the MYC and ID3, TCF3 mutation. Hodgkin is difficult because Hodgkin lymphoma, by definition, you have few cells among many reactive small cells. So if you do NGS, difficult to detect mutation. There is abnormalities in Hodgkin lymphoma, but it's still in research, mainly single cell sequencing than real practical approach. Follicular lymphoma, we described the mutation in follicular lymphoma, all of this, especially EZH2 and many chromatin modifying agent, a marginal zone with KLF2 and Notch1, TB53. Mutated CLL is enriched with MYD88. So this is why MYD88 is not specific. It can be seen also in LBL, MYD88 and CXCR in Waldenstrom macroglobulinemia. So this is mainly the mature B cell. Now let's move to the diffuse large B cell. Diffuse large B cell is by definition a heterogeneous group. So the definition, you have diffuse, you have large cell stained positive with B cell marker. So anything that fits with that will be under diffuse large B cell. And we have been trying to differentiate this for a long time. So we start first with the morphology, differentiating the centroplastic from immunoblastic, from anaplastic, and the morphology does not always correlate with prognosis, even though some of the morphology is worse. Then we start with the cell of origin classification, the CGB versus non-CGB, ABC subtypes. It work well with R-sharp treatment, but still it's not the best. There are many cases unclassifiable in between. And right now, many mutation has been described in diffuse large B-cell lymphoma. Many of them has really prognostic significant. Still, they are in treatment-wise not really used a lot, but prognostically it has significant. Most of these genes under either BCR signaling pathway or toll-like receptor signaling, lymphocyte differentiation. Some of these genes work as DNA repair or cell cycle. Some of these genes important for lymphocyte activation, some of them in chromatin modification, and some of these genes very critical for immune surveillance. I will not touch in high-grade B-cell lymphoma because Dr. Nasser gave us excellent overview about high-grade and make rearrangement. But let's see how we can classify the diffuse large B-cell morphology. So this is a study from Dana-Farber. They tried to do whole exome sequencing in 300 DLBCL cases. They found 158 driver mutation, almost 17 mutation for every case, and they divide them into 5 clusters. So you can see C1, C2, C3, C4, C5, all of these clusters here, different signature for each group, and they correlate this with the outcome. Then there is another group from the NIH. They also have 574 DLBCL. They did whole exome sequencing, gene expression profiling, copy number changes, and also they add targeted panels. So they focus on 372 genes in addition to whole exome sequencing. And they divide them into 4 groups. EZB, where you have EZ2 and BCL2 rearrangement, and this is the best group. Then B2, BCL6 with Notch2, MCD, MYD88, and CD79A, and Notch1 group, which do the worst. So you can see the survival difference. This is the worst group, and EZB is the best group, and in between. So this has clear prognostic significance in DLBCL. Then there is another group from UK. They have 928 DLBCL patients. They do targeted NGS, including 293 genes, and they divide it into 6 subgroups. And these are also different subgroup with Notch2, BCL2, MYD88, and others. And there is a group where not otherwise specified or not otherwise classified, where it doesn't fit with any cluster here. So this is a little bit confusing, but right now we know that we can put these 3 group or these 3 classification into one group that fits both, according to the NIH and UK and the Dana-Farber classification. They fit with almost these 6 groups. So the first group is EZB, which has BCL2 and EZH2 and others. Then STC2, where you have SOX1 and TIT2. Then the TB53 group. Then the Notch1 group. Then the BN2, Notch2, and BCL6 rearrangement. Then the MYD88 and CD79V. These had bad prognosis, some intermediate prognosis, and this has good prognosis if no MYC rearrangement. Again, this associated with GCB morphology, and this one with ABC morphology, or self origin. So this is the DLBCL classification. This is the best way to handle all of the subgroups. This has prognostic significance, as you can see, and also has some therapeutic. So we have EZH2 inhibitor, we have BCL2 inhibitor, and we have many inhibitors that work in BIC3 pathway and BCR pathway and other JAK-STAT pathway. So if you find a mutation, all of these treatment options the patient can get, maybe not so all of these patients, all of these classification they receive are sharp, most of them. But if the patient failed the first-line therapy, maybe they will benefit from this targeted therapy. So this is the diffuse large B, and we finished small and large B cell. Let's move to T-cell lymphoma. Some update about the molecular abnormalities within the T-cell lymphoma world. Now we have the nodal follicular helper T-cell. It has 3 subtypes. The angioimmunoblastic, it used to be the angioimmunoblastic T-cell lymphoma. Now it's a subtype. Then follicular subtype and NOS. They share the same molecular and abnormalities, even though they have different morphology. It seems that this disease is a progression. So all of the follicular helper T cell, they have cytogenetics abnormality. They have many other clonal abnormalities. Some of them, around 10% to 25%, lack T cell gene rearrangement. So if you don't have T cell gene rearrangement, it does not rule out this diagnosis. Interestingly, 40% of them have IGH gene rearrangement. So you can find IGH gene rearrangement, and you can miss the T cell receptor rearrangement within this because of the abnormal B cell in the background that can stain with ABV. Now, the mutation common here is TIT2, DNMT3A. All of these are CHIP mutation. IDH2 is very enriched in this group, and ROA is also very enriched. Most of these cases, almost 90% of this diagnosis will have mutation, at least of one of these. So if you are in doubt, you can do NGS, and you will detect one of these mutations in these cases. It can help if the diagnosis is challenging. Next is ALCL. Again, this is well known for all of us. It's the CD30 positive with hallmark cells. The ALK positive group, the fusion with the MBM1 Barton 2 5 fusions is well characterized for ALK positive. You can call it ALCL, ALK positive or ALK positive ALCL, depending on which classification you choose. But this group is enriched with Notch1 mutation, and Notch1 can serve as a target for these patients. In terms of ALK negative group, this is a heterogeneous group. We used to call them as DUSP22, TB63, and triple negative. Now, we know that it's beyond that. So many mutations can happen even within the DUSP22 and TB63. It seems that DUSP22 and TB63 is mutually exclusive, so you cannot get both. TB63 usually associated with worse prognosis, but many other mutations can happen in ALK negative. And this is why this entity, I think, will get more attention in the next WHO as better classification and better characterization, especially that other fusion has been described in ALK negative, like RAS1 fusion, similar, let's say, to lung carcinoma, where you have RAS1 and ALK1, TYK2 and TFR fusions, all described in ALK negative ALCL. Sorry. Okay. Next is peripheral T-cell lymphoma. So peripheral T-cell lymphoma, you are aware of this gene expression profiling, where you can differentiate this, peripheral T-cell lymphoma. It's a group of diseases, very heterogeneous, that does not fit with any other. So it does not fit with AITL, does not fit with ALCL. Then we describe it in anaplastic large, describe it in BTCL. Based on gene expression profiling, we found two markers, the TBX21 and GATA3 gene expression. That's totally different. GATA3 is associated with worse prognosis compared to TBX21. And now there are multiple, or there is a recommended immunostains that you can do algorithm similar to Hans algorithm, where you can do to classify T-cell lymphoma either as GATA3 signature or TBX21 signature. The mutation profile is different. So TBX21 associated with TIT1, TIT3, and DNMT3A. On the other hand, GATA3 is associated with TB53 and B10 loss and CDKN2A, 1B loss, RB1 mutation or deletion, gain of MYC. So all of this is bad. So this is why you get GATA3 has a worse prognosis for this regard. Primary nodal EBV positive NK cell lymphoma. This is a new provisional entity in both ICC and WHO5, usually in elderly, poor prognosis. And there are many mutations described here, including STAT3, TET2. All of them is a potential target. Still, this area needs more attention because this disease is very aggressive. So this is a summary of the nodal T NK cell lymphoma. We described the T follicular helper cells with specific mutation IDH2, RO-A, and TIT2, DNMT3A. Then we describe ALCL. We describe the BTCL with some mutations, and we describe the primary nodal EBV positive T NK cell lymphoma. There are extranodal T cell lymphoma. I will not go deep into this because there is another talk about about cutaneous T-cell lymphoma. But with cutaneous T-cell lymphoma, we have a good mutation, BLCG1. This is the next target. So this will be a very critical mutation. And breast implant associated ALCL. Even though the name is ALCL, it's totally different than ALCL. So it doesn't have DUSP22, doesn't have TB63, doesn't have ALK. It has STAT3 mutation, and STAT3 mutation, it's not specific, but very common in ALCL, breast implant associated. Hepatosplenic T-cell lymphoma associated with several mutations. Intestinal T-cell lymphoma, either enteropathic or monomorphic. Epitheliotropic T-cell lymphoma is associated with this mutation. Then we have the extranodal NK T-cell lymphoma nasal type associated with DDX3 mutation and TB53 as worse prognosis for this patient. So just for the sake of the time, these are the selected type of lymphoma that we see. I will talk you through what we do at King Faisal in my lab for lymphoma. So we have this lymphoma NGS panel. Still, it's under validation, but in the final stages, we expect to go live in January 2025. So these are around 70 genes commonly mutated in lymphoma, and this panel is DNA only. So we only do DNA, not including any fusions. There are other tests in the market where you can do DNA and fusions, but we focused here on DNA, and you can see most of these genes are critical for prognostic significant, and some of them even therapeutic, like EZH2 and BRAF, for example, for hairy cell or something like that, if it's seen. Now, there are other tests like clonality testing. We used to do it by fragment analysis to see if there is a clonal B cell or T cell, but now there is NGS-based clonality testing that can be done, especially for MRD and BALL and multiple myeloma and CLL. There is some FDA-approved one for diffuse large B cell lymphoma, like clonoSEQ, and LymphoTrack, all of them available in the market. Very sensitive, good for B-cell lymphoma as a clonality testing or for follow-up. And we like to do it as informed clonality testing, which means we do the testing at time of diagnosis. We know exactly what's the clone present, what's the rearrangement in this patient. Then we can follow them and we can detect up to 0.01% if there is residual disease. Cell-free DNA is also critical, and it's coming to the market. Even in Hodgkin lymphoma, there are many cell-free tumor DNA, and especially with lymphoma, I think it will work the best. We started the first with the NIPT testing for fetal DNA with the pregnant mother. Then we found the tumor DNA. So if these lymphocytes are circulating in the blood, definitely you will find the mutation in cell-free DNA. So we are also planning to have this maybe in 2025 or 2026 at our hospital to offer cell-free DNA to follow up these patients, especially if biopsy is difficult. And many times after chemo, difficult to find a biopsy. If you find AVG, avid lymph node, you don't know if it's a relapse or not. So cell-free DNA will be very helpful in these cases. So to sum up, this is the take-home message. I think my presentation has a lot of genes. If you don't remember all of them, that's fine, but at least this is the critical part here. The significance is here. So lymphoma is a heterogeneous disease. DLBCL is very heterogeneous. So we have many mutations. None of them is specific, but they affect the patient in terms of prognostic and may have also therapeutic implication. Morphology is very critical, so we will not move away from morphology. Molecular is already supporting the morphology. Lymphoma NGS becoming a standard of care now. Lymphoid neoplasm patients should offer lymphoid NGS panel. It can give therapeutic, prognostic, and predictive information. Whole exome sequencing or whole genome sequencing is good if you are suspecting germline, because some people, they have multiple family members with the lymphoma. So if you think they are at higher risk of lymphoma from the germline perspective, then whole exome sequencing will be very helpful. Morphology, similar to morphology, NGS molecular test will depend on the quality of the sample. So if you have bad sample, it will be difficult to get a good molecular result. Standardization, availability of these tests is the challenge. So not every hospital have NGS lab or able to have the lymphoma NGS. The panels are different, so every hospital have different methodology, different genes. The ability of the panel to detect copy number changing structural variant is also different. So you may see lymphoma panels in different labs, but they perform differently because they are designed differently. Excisional biopsy is very critical. So if you are talking about molecular, we need tissue for not just for diagnosis, not just for IHC, not just for flow. Now we need tissue for the NGS test. So we are always like to have excisional biopsy, if not at least a good core needle biopsy. FNA will work for molecular tests, but it's not enough for diagnosis because we need to see the architecture. Clonality testing is critical and is coming to the market. MRD testing and cell-free DNA is approved in DLBCL. Most genomic alteration are not integrated in the first-line therapy, and this is also very critical. So most of these mutations are important in terms of prognosis or therapeutic, true, but not at time of diagnosis. So most of these patients will receive the standard of care therapy. If they relapse, if they progress on therapy, then you may think about this mutation. And this is why the turnaround time for this test is not critical. So you can do the lymphoma NGS and receive the result after 1 month. That's fine. This is different than leukemia, where they need the result urgently because some of the mutation integrated in the first-line therapy. Finally, knowledge of the biological information of the lymphoma allow earlier diagnosis, can also help in screening and better therapy and better understanding of this lymphoma so we can serve our patients better. And thank you so much.